My client is a very active retired fireman who injured his low back and has sacroiliac area pain on the right side. He had a knee scope, how long ago?
2 months ago.
2 months ago, and has been receiving physical therapy for his knee. What I find with his knee is that he has good posterior spring of the femur, but his knee is maintained in slight flexion. And I don't know if the camera angle can capture that, but this thigh is more anterior than the other side. And as a result of that, his patella is very compressed. He's basically functioning with his knee bent because his hip is slightly bent in flexion as well. And so the right patella has good free mobility, medial and laterally, and I can squeeze it and pop it forward just slightly. I can scoop it and I can push it inferiorly and then superiorly. It has all those motions. And this patella has just minimal side-to-side movement, very, very slight. And when I try and push it inferiorly towards his foot, it has minimal movement. Same thing going upward. And when I try and squeeze it, the tissues are just too tight that I can't pinch it and get a little bit of upward movement. Now when I spring the middle of his thigh, we have spring mobility on the right side, and on the left side we don't. And that's because his hip is being maintained in a position of slight flexion. He has much less hip extension on the left hip. So I'll come to that in a short while. He also has a twisting pattern in his pelvis, and we name that for the direction in which passive motion is lost. Positionally, I'm under the ASIS, and this is not subtle. I'm going to move my camera angle. So I'm under the ledge of the anterior superior iliac spine, also called the ASIS, and this one is distinctly lower. It is not subtle. And the right one is somewhat forward towards the ceiling. Now this is what I call the anterior shelf, which is much easier to palpate than the ASIS. And it's this flat portion of the anterior ilium. I call it the anterior iliac shelf. And it's very easy to see that the shelf on the right side is lower. This is a three-dimensional twisting pattern of the pelvis moving with his low back, his trunk, and moving on the hips. Okay? If it was a twist inside the SI joint, I wouldn't even be able to measure that because there's so little movement in the SI. But the whole pelvis can move as a unit without requiring a sacroiliac explanation. However, that pattern does block motion moving through the SI. I'm trying to spring the right pelvis, and I'm pushing with a moderate amount of force, and there's no movement. And you can compare that to the left side. You can see that when I push with just about 15 pounds of force, his pelvis twists and then comes to an end point. But at that end point, I can add additional force and induce motion. And so we name this anterior ilium, but it is a twisting pattern of the entire pelvis. We have pretty free mobility in his right hip. So he has 90 degrees of straight leg raising. And I can take the femur and scour the hip, making circles. And that movement is very smooth. He reports pinching in the right hip with sudden movements, and it's a very sharp pain. He describes it as a nerve being plucked like a guitar string. And he has less hip flexion on the left hip. So we come up, well, we do get to 90, but we can't go beyond that. Okay, I'm not able to go beyond 90. And when I try and do that scour test, it's very limited. There's less range rotating it anti-clockwise. All right, let's have you lie on your stomach, please. He also has blocked inferior mobility going through the right side of the pelvis, whereas he has normal inferior mobility on the left side. And he has normal upward mobility. Translation, I see his head bob, so the force translates through the pelvis, through the SI joint, through the spine. And we have the same thing on the right side. Okay? So this is where I'll show you the limitation of left hip extension. I can passively extend that hip 20 degrees. On the left side, I don't even achieve 5 degrees. I cannot extend his left hip. That's very easy to treat. We're going to restore that motion. And I'll demonstrate some muscle inhibition as well. Let's have you sit up. Face the window. And you do have some quadricep inhibition. You have to wear a brace whenever you walk. This is 2 months post.
Oh yeah.
After the scope.
Yeah, it's pathetic.
And why do you have to wear the brace?
My MCL got re-sprained when a dog hit me from the side.
Yeah.
But ever since my surgery, I've had this crazy inhibition of my quads, where I almost can't will them to work.
Okay. Does the knee give out when you walk?
Yeah, it gets wobbly sometimes. I'll get sometimes get some tingles, down my leg.
Okay.
And then it's like, I lose stability in my knee.
All right. Okay, so let's test your strength. Put your knee out straight. And we tested the other side, and it was very strong. Put the right one out straight, and that's just solid. We tested your knee flexors, and they were quite strong. And now I will, don't let me bend it, okay? 1, 2, 3, go. And you can see how easy it is for me to break that. Okay? So there certainly is muscle inhibition. Okay? Go ahead and lie on your back. I noted in walking you don't have right arm swing. So that takes me to screen the AC joint. And you have good mobility of the clavicle. I can spring your clavicle inferiorly and posteriorly. But I noticed that this shoulder is more forward than the other side. And so what I'm going to do now is capture the anterior portion of the scapula, and that's called the acromion. And it connects with the clavicle, that's called the AC joint or acromioclavicular joint. And when I try and spring it laterally, I'm actually going at a 45-degree angle this way. Okay? And there's no give. That joint is compressed. So your scapula is being maintained in a protracted position. On the left side, I have free and easy mobility. And that's easily treated.
Yeah, I often get muscle knots and cramps by my right scapula.
Do you?
Yeah.
Okay. The other thing I found was that your head looks like it's maintained in extension, your chin being higher than your forehead. You did describe a face plant where you hyperextended your neck. And when I test traction to the upper cervical spine, you can only do that by contacting in front of the ear, basically contacting the temples, And that's because the upper two joints in the neck are right below the earlobe, but all the other facet joints are in the back of the neck. Okay? So I'm going to test distraction of the upper two joints when I just very slightly elevate your mastoid. We get a little bit of side bending of your neck. So it's my belief, and we can also test left and right rotation through the mastoid process. And so it seems like the upper joint moves, which is the occiput joining the first vertebrae, occipito-atlantal joint. And I'm now testing traction, and I can take up a little bit of slack, but it takes up rather quickly. And then when I try and get some spring mobility, there's no mobility. Can you feel that?
Mm-hmm.
Okay.
Yeah.
So I'm blaming the second joint in the upper neck, which is called the atlas and axis. So it's the atlantoaxial joint. And again, there's just no traction mobility there. When I put you at extension, we have the same phenomenon. I take up the slack so quickly. There's just that tiny little bit of motion I can take up, and then there's no more motion. And then I try and traction it, and there's no motion there. Okay? When I put your neck in flexion, I can then take up the slack, and now I can spring it, and there's distraction, mobility throughout your spine. In fact, I see your feet move up and down. So the motion translates through those upper joints all the way down your body with a very small amount of force. This is probably between 10 and 15 pounds to take up the slack, and then between 10 and 15 pounds to do that traction. Okay? So that's a pattern that is easy to treat. Okay? So there are certainly things that we can do with you to improve function in your body, and this is an example of the whole body approach to evaluating a person. And the other thing I'll mention is that you do pronate in both feet. You have greater mobility in your foot and ankle joints than the average person. You've tried foot orthotics and arch supports, and those make you uncomfortable. But we did experiment with a medial wedge on both sides, just a 6-degree wedge, where it's elevated on the medial, the inside part of your heel. And tell us how you felt with those wedges.
I felt better instantly. I felt like I was almost a normal person walking again.
So what was abnormal? What elaborate?
I didn't feel the stress in my knees, and it just, my feet felt like they were in the proper contact with the ground. And I wasn't trying to do all sorts of weird compensations, trying to not be in pain while I was walking.
Interesting. So this is what a heel wedge is, and with your foot type, I put the elevated aspect on the inside of the heel. And you can find these online. I have a couple of examples. You can type in my last name in heel wedge. That's H-E-S like Sam, C-H, heel wedge. And that'll give you a deeper understanding of their use. It's remarkable how many people I have that have custom orthotics that were expensive, and you look at the back of the heel and it's just straight. And I add a heel wedge either to the outside or to the inside. And for many it's very helpful. I don't know why that aspect of heel movement is not being evaluated.
Oh yeah, that was almost magical.
My last comment is that I also have YouTube videos on the upper cervical spine, so you can type in my last name Hesch and then upper cervical spine, and I have a book chapter on treatment technique that I've developed for treating it. And you'll notice that I'm treating it with traction and with forward bending. And you will not find that in other YouTube videos. Only the videos that have my name demonstrate that technique. And it seems like there are so many videos where they do a sideways treatment to that joint, to the atlantoaxial joint, and they treat the rotational aspect of the atlantoaxial joint. There's specialty chiropractic techniques that treat laterally, but do not evaluate and treat this distraction or this forward movement. I have a book chapter coming out very, very soon on that joint. Again, it's called the Atlantoaxial joint. So I'll stop filming here, and we'll get to work in treating you, and we will film the response to treatment. Thank you.
Okay, great.